Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
I'd like to welcome you back to another episode of Thinking Thoracic. I'm Hari Kashawa from the University of California, Irvine, one of the hosts. And I have the pleasure of having Dr. Jeff Yang, who's actually one of the co-hosts, but also a guest this time, as well as Miss Alex Potter. Dr. Jeff Yang is out of MGH, and Miss Potter is a clinical research coordinator and the president of the American Lung Cancer Initiative. And this is a great episode as we'll be discussing the J. Maxwell Chamberlain Memorial Paper, which was presented as a plenary paper at the STS in 2025. So welcome to both of you.
Great. Thanks so much for having us.
So let's just get started. Since your study was about lung cancer screening, Dr. Yang, could you just take us through a little bit about the current USPSTF recommendations for lung cancer screening and kind of a little bit of how these recommendations were developed?
Great. Well, thanks again, Hari, for having us. The 2021 USPSTF guidelines were based off of the National Lung Screening Trial, which is a large-scale randomized trial randomizing participants to chest X-ray and CT scan for 3 years, and looking at specifically participants who had a high smoking history. So people who were age 55 or greater, had a 30-year pack year smoking history or more. And the most recent guidelines, which were revised a little bit, are specifically looking at people who are age 50 to 80, have a greater than 20 pack year smoking history, and currently smoke or have quit within the past 15 years. And these guidelines, they're a step in the right direction. They're certainly better than the 2013 version, but even with the revisions, only 50% of lung cancer patients right now in the United States would be eligible for lung cancer screening. So another way to think about that is more than half of patients who have lung cancer right now are not eligible to get screened. And that's because the lung cancer screening criteria are too restrictive. And probably because of, as you're getting back to your question of how they were developed, it's because the randomized trial, the National Lung Screening Trial, was mostly white men with high pack year smoking history and not representative of all patients and all people in the US who are at high risk of developing lung cancer.
So there have been prior studies that have investigated the proportions of patients with lung cancer who have met the USPSTF criteria. And what did these prior studies find? And I'll ask Ms. Potter. It'd be great to hear from you about that.
Yeah, so just to follow up on Dr. Yang's comments, one of the concerns was the U.S. Preventive Services Task Force, when they implemented their criteria for lung cancer screening, they took from the National Lung Screening Trial. And one of the issues was the National Lung Screening Trial, those criteria were used to identify a population at highest risk, to study a very specific question of whether screening with low-dose CT would would reduce lung cancer mortality. And so what's happened is in taking those very strict criteria used in a trial setting and trying to apply them to a population level screening program, it's the problem is that they are too restrictive. And so prior studies have started to look at, well, how many patients with lung cancer would have actually met the criteria set by the USPSTF. And there's been a number of analyses, probably ranging between around 10 analyses so far, that have shown that only about 50% of patients with lung cancer would have actually met those criteria. And so, really, a growing body of evidence that suggests that these criteria that are intended to identify people who are ultimately going to develop lung cancer are actually missing a very large percentage of those who actually do develop lung cancer.
So, Ms. Potter, what have been some of the revisions that have been proposed for the USPSTF guidelines or recommendations throughout the years since the studies have come out?
Yeah, so there's two major changes that have been proposed. The first is looking at the pack year smoking history requirement. So currently, the USPSTF guideline requires individuals to have smoked at least 20 pack years. And one of the proposed revisions is instead of requiring a pack year requirement, is to require a 20-year duration requirement. So to switch from pack years to duration. And Dr. Yang and I previously published a paper in the Journal of Clinical Oncology this past year, showing that when you replace the 20 pack year requirement with a 20-year duration requirement, there are two really important things that happen. The first is that more patients with lung cancer would qualify for screening. So you increase opportunities for early detection among a population at very high risk of lung cancer. And the second really important thing is the disparity in eligibility between Black and white individuals is eliminated when you switch from pack years to duration. So that's one of the key changes that have been proposed. The other one is removing the 15 years since quitting requirement that's currently included in the USPSTF guideline. So right now, people who have, smoked, even smoked over 20 pack years, if they have quit smoking over 15 years ago, they're currently excluded from the lung cancer screening criteria and not eligible for screening. And so one of the proposed revisions that has been led by the American Cancer Society has been to actually remove that criteria and open up screening to people who meet certain age and smoking requirements, but don't impose any restriction on the number of years since quitting.
And just to add on that, the American Cancer Society guideline right now is if you're between 50 and 80 years old and you have a greater than 20 pack year smoking history, you are eligible to get screened for lung cancer. So there is no 15 years since quit restriction. And then the NCCN guideline is even more expansive. It's if you're over the age of 50, so there's no upper age cutoff, and then you have a 20-year pack year smoking history or greater than 20-year smoking history, then you're eligible. So there's no restriction on did you stop smoking within the first 15 years. And I do want to turn it back to Alex to just talk a little bit about the disparities in lung cancer screening eligibility that you found.
Yeah. So in addition to one of the concerns with the current USPSTF criteria that we touched on previously, which is that about half of patients aren't currently eligible. Another big issue when it comes to lung cancer screening eligibility criteria is that there are very large disparities in eligibility, particularly by race. And prior studies have shown that Black individuals at high risk of lung cancer are less likely to be eligible for lung cancer screening compared to white individuals diagnosed with at risk for lung cancer. And it's a very large difference. So in our prior study, analyzing data from the Southern Community Cohort study, we found that only about 57% of Black patients with lung cancer would have qualified for screening. compared to about 75% of white patients with lung cancer. So, mid 70% to less than 60%, a really big difference. And that disparity in screening eligibility is eliminated when you replace the pack year requirement with a duration requirement. Um,
No, this is great, and this is a great way of thinking about this because, of course, as we all know, if we find it early, we can essentially hopefully get them to treatment or curative treatment, get patients there earlier. And when you're talking about disparities, we know that a lot of Black individuals, cancer is kind of found later. And this, you're kind of clearly talking about that with what you've shown in some of your previous studies. So with that, let's get to your current study. Can you, Ms. Potter, could you describe the objective of this study and kind of how you came to that?
Yeah. So in this study, we sought to analyze data from the Boston Lung Cancer Study, which is a large cohort study of over 12,000 patients with lung cancer. And we analyzed 7,000 as part of this study. And we had two key objectives. The first was to evaluate the proportion of patients with lung cancer who would have qualified for screening using different eligibility criteria. And we specifically looked at 5 different eligibility criteria that used categorical age and smoking history criteria. So that included the USPSTF guideline, the current one, um, our 20-year duration guideline, which replaces the 20 pack year requirement with a 20-year duration requirement, the American Cancer Society guideline, which is the same as the USPSTF guideline, but removes the 15 years since quitting requirement, and then 2 versions of the NCCN guideline. The older version, which we call the NCCN Category A, and that's age 50 plus and 20 or more pack years of smoking. And then the newest NCCN guideline, which was just published back in October of 2024, which notably included a duration threshold. So this newest NCCN guideline now recommends screening for people over the age of 50 with either 20 pack years or more, or 20 years of smoking or more. So it includes that duration threshold. So we looked at those 5 categorical guidelines and how the proportion of patients with lung cancer, how that varied across those different guidelines. The second objective we looked at was if we could supplement these categorical age and smoking history criteria with the results of a lung cancer risk prediction model called the PLCO M2012 model. And we looked at, of those who were ineligible for screening under the categorical age and smoking history criteria, how many patients could be rescued by having a PLCO risk score high enough to potentially qualify for screening. So those were the 2 key objectives.
Wow, you went through a lot right there. So I'm just going to come to your second objective because this is phenomenal. I just would like to have you explain a little bit more about the PLCO M12 model, or sorry, M2012 model that you talked about.
Yeah, so the PLCO model, it's different from the current USPSTF criteria, which are based solely on categorical age and smoking history criteria. And when I say categorical age and smoking history criteria, I mean the 50 to 80 years of age, over 20 pack years, actively smoking or quit within the past 15 years. The PLCO model is a risk prediction model that includes 11 different lung cancer predictors. And those include age and smoking history, like intensity and duration. But it also includes other variables like family history of lung cancer, COPD, BMI, and other factors that the thought is could potentially give a better assessment of an individual's risk of developing lung cancer, and could identify people who potentially don't meet the USPSTF criteria. So they're, have 19 pack years, or they quit 18 years ago, but their risk of lung cancer is quite high. And so they could potentially be identified by a risk prediction model.
Yeah, that's interesting. If you have kind of these 11 different other variables that each have a little bit of a weight, then the PLCO model might help to identify some of these patients as well. So let's get now to the key findings. You kind of had these two different major objectives, and you went through it with the data set. Let's go through some of your findings that you have.
So the big finding was, so in our study we analyzed 7,186 patients. So this is the largest analysis on this topic to date. And we found that of those 7,186 patients, only 46.1% would have met the USPSTF criteria. So less than half of patients with lung cancer in this very large data set would have qualified for screening and potentially, have been able to undergo screening. Um, the primary reason for being ineligible in our cohort was having quit over 15 years ago. So, 52.1% of patients in our cohort had formerly smoked. And of those people who formerly smoked, 56% had quit over 15 years ago. So, in other words, over half of people who formerly smoked and were diagnosed with lung cancer had quit over 15 years ago and would have been excluded by that 15 years since quitting requirement in the USPSTF guideline. And then what we did was we evaluated whether these different categorical age and smoking history criteria would select a higher proportion of patients with lung cancer. And so we looked at what we call the 20-year duration guideline. And as a reminder, that's taking the USPSTF guideline and replacing the 20 pack year requirement with a 20-year duration requirement. And we found that the 20-year duration guideline increased the proportion of patients who would have qualified from 46% to 49%. So it was a small increase, and we can discuss more about why it was small. But the really important thing to note is that that simple change from going to pack years to duration primarily expanded eligibility to patients who were female, from racial and ethnic minority groups, and younger. So it really opened opportunities for lung cancer screening to patient populations that have historically been disproportionately excluded from the criteria. So a really important change when we're thinking about equity. The other guideline we looked at was the American Cancer Society guideline. So that's removing the 15 years since quitting requirement. And we found that when you remove the 15 years since quitting requirement from the USPSTF guideline, the proportion of patients who formerly smoked significantly increased. Only 36% of patients who formerly smoked would have met the USPSTF criteria. This was increased to 65% under the ACS guideline. So I can repeat that again. So only 36% of patients who formerly smoked would have qualified under the USPSTF criteria. Under the ACS guideline, which removes the 15 years since quitting requirement, 65% of those patients would have qualified for screening. Yeah, so that is a really important finding of our study, which is that this simple change of removing the 15 years since quitting requirement nearly doubled the proportion of patients who formerly smoked diagnosed with lung cancer that would have qualified. And this again goes back to the finding I had mentioned earlier, where 56% of patients who formerly smoked at the time of diagnosis had quit over 15 years ago. So you can see that removing this restriction from the USPSTF criteria really opens up opportunities for lung cancer screening to many of these patients who formerly smoked who get lung cancer.
Yeah, I think that's a great point. Essentially, what you're finding is that there's a lot of lung cancer patients, because the Boston Lung Cancer Study, it's everybody in this cohort has lung cancer, and we're trying to look at the criteria and see whether these patients who have lung cancer, if they were even eligible to be screened. And what you find is that a lot of these lung cancer patients had stopped smoking a long time ago and would not be eligible to get screened. And it really highlights that the current guidelines are too restrictive. And in this cohort, the 15 years since quitting requirement is very, very restrictive. And as you can see from this finding, about basically almost double the number of people who used to smoke in this cohort would now be eligible to get screened if you get rid of that one very restrictive requirement of the 15 years since quitting requirement.
So, Ms. Potter, your study has shown some amazing results here, like what we've been talking about. What do you think is going to be the biggest aspect of the study that's going to now change clinical practice?
After we evaluated the 20-year duration guideline and the ACS guideline, we evaluated the proportion of patients who would have met the NCCN guideline. And so we looked at both the old NCCN guideline, which recommends screening for individuals who are over 50 and have smoked 20 or more pack years, as well as the new NCCN guideline, which was recently published in October of 2024, which recommends screening for individuals over age 50 with 20 or more pack years or 20 or more years of smoking duration. And we found that under both versions of the NCCN guideline, a greater proportion of patients would have qualified. And importantly, under the newest version of the NCCN guideline, 72% of patients would have qualified for screening. And that's a huge jump in comparison to the 46% who would qualify under the current USPSTF criteria. So we find that in the newest version of the NCCN guideline, which removes the 15 years since quitting requirement, includes a 20-year duration threshold, and removes the 80-year upper age bound from the USPSTF criteria, you really open up eligibility for lung cancer screening, and nearly 3/4 of patients with lung cancer would now qualify for screening.
So, Alex, this was a phenomenal part of the first objective that you had in your study. I've been so intrigued about the PLCO M2012 risk prediction model that you had talked about. Could you talk a little bit more about that aspect of your study?
Absolutely. So for the second part of this study, we then asked the question of, can we supplement these categorical age and smoking history criteria, so the USPSTF criteria, 20-year duration criteria, ACS or NCCN criteria, with the results of a lung cancer risk prediction model? And what that means is we looked at patients who would have been ineligible for screening under those criteria, and we looked to see what their 6-year PLCO risk score was, and what proportion of those patients had a PLCO risk score over 1% and would potentially be, eligible for screening. And what we found was of patients with lung cancer who were ineligible for lung cancer screening under the USPSTF criteria, 52% had a PLCO risk score over 1%. 48% still had a PLCO risk score below the 1% threshold. So this, finding suggests that applying a risk prediction model, it could help supplement USPSTF criteria and identify some patients who are currently ineligible at high risk of lung cancer, but there's still many patients who would not meet the USPSTF criteria and also wouldn't be rescued by a risk prediction model. And we did dig a little bit deeper to try to understand, well, what characteristics of patients are being missed by the PLCO model. And what we found was the PLCO model is really good at identifying people who are over the age of 80 and at identifying people who have smoked a lot but have quit over 15 years ago. Because both of those are criterion in the USPSTF guideline that prevent people from getting screened. And so the PLCO model is able to identify those people and potentially could be used to offer screening to them. But what was important was when we looked at what were the characteristics of people missed by the PLCO model, we found that most people who had smoked fewer than 20 pack years had a really low PLCO score. And we found that the PLCO model missed 89% of patients who had smoked fewer than 20 pack years. Yeah.
That's really interesting. So potentially that PLCO risk model might not help some of those populations you had talked about before, especially maybe Black and women population.
Yes, that's exactly right, which is that the PLCO model misses a lot of patients who had smoked fewer than 20 pack years, and that patient population is one that's disproportionately comprises patients who are female and from racial and ethnic minority groups. Um, and I think really highlights the importance of thinking about including a duration requirement into the lung cancer screening eligibility criteria, because that is one modification to the guideline that does address some of these disparities in eligibility that aren't addressed by um, other modifications like removing the 15 years since quitting requirement, and also aren't addressed by supplementing the criteria with the PLCO model.
So that's great. Can you then just describe the key findings that you found in your study and kind of the major findings? You kind of mentioned it just now with the duration, but what do you think are the major findings from this?
Yeah, so the key takeaways from our study are first, it's really important that people know that currently only 46% of patients diagnosed with lung cancer in the Boston lung cancer study would have qualified under the USPSTF eligibility criteria. And this is, again, it's the largest analysis on this topic to date, including over 7,000 patients with lung cancer. And it adds on to a growing body of literature that supports that only about 50% of patients with lung cancer in the US would have met our criteria for lung cancer screening. So, really further emphasizes this huge gap in our lung cancer screening guidelines. Another key finding is revising the USPSTF criteria to include a smoking duration requirement is important because it primarily expands eligibility to individuals who are female, from racial and ethnic minority groups, and younger. These are all patient populations that have historically been disproportionately excluded from the lung cancer screening eligibility criteria. And so, a really important change to the guideline when we're thinking about expanding opportunities for early lung cancer detection to these populations. The third key finding is removing the 15 years since quitting requirement significantly increases eligibility for patients with lung cancer who formerly smoked. In our study, over 50% of patients who formerly smoked at diagnosis had quit over 15 years ago and wouldn't have qualified under the USPSTF criteria. And that's a huge proportion of patients. And so by removing the 15 years since quitting requirement, we can expand opportunities for lung cancer screening to those patients. And then lastly, the PLCO model, we found that the PLCO model could help identify certain patients diagnosed with lung cancer who are ineligible for screening under the USPSTF guideline. But it's really important to know that the PLCO model is not perfect, and it missed many lung cancer patients, especially those who had smoked fewer than 20 pack years.
Wow, this is a phenomenal study, and kudos to both of you. This is just a great study and going through the literature. So, Ms. Potter, how do you think your findings are going to change clinical practice with your study?
So I was very excited to see in October that the NCCN had updated their lung cancer screening guideline and had um, in, to include a 20-year duration threshold. And I think that that's a, a step in the right direction for more and more people to begin thinking about expanding the different lung cancer screening eligibility criteria. And so I think our study, you know, adds to the growing body of literature that supports the inadequacy of the current USPSTF criteria, and also suggests that these different modifications uh, can improve the criteria uh, in different ways. I think a key finding of our paper is that the duration requirement, so including a smoking duration requirement and removing the 15 years since quitting requirement, are both really important changes to the criteria, and they're important for different reasons. The duration requirement addresses issues surrounding disparities in the eligibility criteria, while the removing the 15 years since quitting requirement addresses the very low proportion of patients who formerly smoked who currently qualify. So I think really highlighting how those two changes impact the criteria. I'm hopeful that in the next couple of years, as the USPSTF begins to reconsider their lung cancer screening eligibility criteria, they'll take these findings into consideration and recognize that having less than half of patients ultimately diagnosed with lung cancer being eligible for lung cancer screening is not appropriate, and that we really need to revise the criteria to ensure that they capture the population at risk of lung cancer and include individuals who ultimately develop lung cancer.
I think those are both great things to bring up. Dr. Yang, what are your thoughts and what do you think are going to be the key takeaways from your study that are going to change clinical practice?
Well, thanks again, Hari, for having us. I think in terms of this study, it really highlights the inadequacies of the USPSTF eligibility criteria. And then the next time the USPSTF meets, I think it's going to be potentially in 2027, 2028. And really hope that as a field with thoracic surgeons and pulmonologists, epidemiologists, medical oncologists, radiologists, everybody, primary care doctors, everybody who is in the lung cancer screening field, we really need to raise awareness about how inadequate these guidelines are and to generate studies like this where it really brings into attention the degree of inadequacy of the eligibility criteria. And hopefully we'll then apply enough pressure to get some kind of improvement in the guidelines. I think, as you can see, the American Cancer Society and the NCCN, they've already moved towards more expansive lung cancer screening eligibility criteria. One thing I don't think we quite talked about, because we assume everybody knows this, but it's worth repeating, is that only 15% of people who are eligible to get screened are getting screened. So that is an uptake issue. But if you look at all the lung cancer patients as a whole, half of lung cancer patients, so every year about 130,000 patients with lung cancer are not eligible to get screened. So then there's an eligibility criteria. And so if you combine both problems, really what we have is this huge under-screening issue. It's not an over-screening issue. And I think there is a concern among some folks that if you screen too many people, like if you broaden the criteria too much, that you end up having too many false positives and that the harms might outweigh the benefits. And that might be something we'll talk about in a later Thinking Thoracic podcast. Hari, I know you've done research in this area yourself, and both of us are in the lung cancer screening task force. We know that the benefits of lung cancer screening far outweigh the harms. And if you broaden the eligibility criteria, you're not going to tip that balance in the wrong direction.
Totally agree with you. And we can have a whole episode about that aspect of it, kind of the thoughts of negative consequences of screening. But I think what you guys are doing, what you guys have shown here, both of you, is phenomenal in the sense that we should be changing this duration from pack years. Even the pack years from a recall bias is so hard for patients. And then, of course, the 15 years since quitting requirement, because the exposure was already there, regardless if it was 15 years ago or 20 years ago, they still had that exposure to cigarette smoking. So this is phenomenal. I think what you've done with this study, and the conclusions are great. And again, kudos to both of you. And I'd like to thank everyone for joining us for this edition of Thinking Thoracic, and stay tuned for further episodes. Thank you again.
Amazing
listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.